Another things that we can see looking at the data in the information system is not only that the patient die more, but they die before the general population. So the length of the life is reduced. And you can see here, for example, that for a patient with alcoholism, after 15 years of contact with the services, 40% of the patient died after 15 years of contacts. Another possibility to use the information system is to use them with a geographical approach. We are used to think that the geographical approach is simply to build maps, but it's not only to build maps, but you can show also the relationship between deprivation and psychiatric services utilization. For example, this study made in London showed the map show the distribution of deprivation in London. If you put the map of the admission for psychiatric reason, you see that the people who is admitted for psychiatric reason comes from deprived areas. And the same if you put the map of the admission for affective disorders. We did some of this study in Italy using our mental health information system, and we have seen that the prevalence of patients treated in our area, in our catchment area, is higher for patients who comes from deprived area. So if you think at the effect of economic crisis that are changing the map of deprivation in our countries, you can understand how the effect of crisis is on services utilization, on mental health services utilization. Not only the prevalence is higher, but also the length of stay in our acute psychiatric ward. And of course, this has an influence on costs. The costs of to treat a patient is higher if the patient lives in a deprived area in respect to a patient who lives in affluent areas. I skip this because I want to show, before concluding, another possible monitoring activity. I am coordinator of an European study on the effect of a funding system on the quality of psychiatric care. We are at the end of the 3 years of this European study, and we are now preparing the final results. But some results is already available, and especially on the work package that measured the quality of care. And I think some of these indicators can be useful for your discussion. For example, the suicide rates in the 9 countries that participated to our study are very different. So before someone said that we have to make Europe homogeneous, similar, but there are still a lot of differences within the European Union. For example, you can see in suicide rates, France has a very high suicide rate, Austria as well, and Finland. The length of stay in the acute psychiatric wards is quite different in Europe. In England it's 51, or at least in the area, in the catchment area that we studied, is 51 days. 51% of the patients stay more than 30 days in the acute ward. So still big differences. There are many differences also in the readmission rates. The revolving door system, you can see that in Norway, for example, 80% of the patients are readmitted after 180 days. Just to show you some indicators and to show you the differences. So we cannot build a benchmark of this indicator, but we can say we are here and we want to change the things in some way, but it's impossible looking at this data to say which is the gold standard. We can look at this data and think and discuss about them. For example, involuntary admission are very high in France, in Finland, in Austria, and in Norway, and are very low in Italy. After the psychiatric reform, the number of involuntary admission in Italy is quite low. This is less useful. Another indicator that we included in our study was if the countries, as in their mental health plan, for example, indication for campaign against stigma and discrimination, or if they made routinely discrimination assessment. And you can see that England, Finland and France and Norway and Romania, they do routine assessment of discrimination, but not in the other European countries. Also we assessed if there are the promotion of cultural competence in the staff about ethnic and cultural disparities. And also here we have found a lot of differences within the 9 countries of the study. And you can see if ethnic disparities is mentioned in the mental health plan. In Finland, in France, and in Romania is not mentioned in the plan. Also we measured the integration between mental and social care. We have measured the number of social workers and occupational therapists that works within the psychiatric services. And you can see that there are big differences. The number is very high in Norway, is lower in England, France and Italy. These are just examples on how using data that usually are routinely collected, so data from the information system, is possible to obtain very good information. The last thing, because you mentioned already this and the very interesting presentation about the mobile services. In this European study we also have seen the distance between services and the place where the people live. And we designed these isochrones around the services. But the results, very important results, is that there are countries, and probably if we do this exercise in Greece, there are countries where many people live far from the services. For example, in Spain, 40% of the people lives more than 30 minutes travel from the services. In Italy, 80% of the people lives very close to the services because Italy is very crowded countries. Okay, I thank you for your attention.